what they lied about said they did.
Who did? In our department?
No, in our field.
That's why they're up here.
Okay, so let's talk about air going in and out of the lungs, ventilation. So I started, golly, a year and a half or more ago to do a series on respiratory physiology, which we finished up last month. So I talked to Bob and I said, do you think I should start that series over again, or should we come up with something else? And he said, well, we have all these new staff, so you might as well just go through it again. So here we are.
Linda, we're new.
I know, we're new again.
So this is a little bit about my philosophy towards evidence-based medicine and respiratory physiology. So I do think we should apply the best available evidence in the care of our patients. I'm a big believer in evidence-based medicine and evidence-based respiratory care. But at the same time, we need to understand the underlying physiology and pathophysiology to apply the evidence wisely. So hence our discussion of respiratory physiology. So these are the topics that I think about in the context of respiratory physiology. So there's ventilation, movement of gas in and out of the lungs, which we'll talk about this morning. There is diffusion, which is the movement of gases across the alveolar capillary membrane, blood flow through the lungs, gas exchange, which has to do with ventilation, perfusion, matching and shunting and so forth. And then blood gas transport, which has to do with hemoglobin function and carrying of oxygen and CO2. Acid base, which actually relates to some of the blood gas transport. And then respiratory mechanics, resistance, compliance, work of breathing, and so forth. And then finally, in control of breathing, the relationship between the brain and specifically the brainstem and the respiratory muscles. So our objectives this morning are to describe the relationship between PCO2, alveolar ventilation, and carbon dioxide production, to compare alveolar dead space, anatomic dead space, and mechanical dead space, to explain the effect of dead space and carbon dioxide production on minute ventilation requirement, and then to discuss a little bit about the role of capnography to assess ventilation, because one of the tools to assess ventilation, in addition to blood gases, is capnography. So illustrated here are some of the normal numbers that I suspect you all know. So normal tidal volume is about 400 milliliters. Turns out that's about 6 mLs per kilogram. So I know when we ventilate patients with ARDS, we talk about low tidal volume ventilation, but it's actually normal tidal volume ventilation. The anatomic dead space is about 150 milliliters, about 1 ml per pound of body weight. Normal respiratory frequency is about 16 breaths per minute, so we multiply 16 times 400 milliliters, that gives us a minute ventilation normally of about 6.5 liters per minute. The alveolar gas volume is about 3,000 milliliters, so there's about 3 liters of gas in the alveoli right now for all of us. Our alveolar ventilation is about 4 liters per minute, so that's the 400 minus 150 times 16. You can double check my math on that if you want. The pulmonary blood flow, or cardiac output, is about 5 liters per minute. So that then results in a ventilation perfusion ratio of 4,000 divided by 5,000, or 0.8. And at any one time, there is about 700 milliliters of blood in the pulmonary capillaries. So we have a lot of gas in the lungs compared to the amount of blood at any one time in the pulmonary circulation. So the point that I'm making from this slide is that all exhaled carbon dioxide comes from alveolar gas. So the dead space is free of carbon dioxide normally. So the dead space has the same composition of gas as the inspired gas. So all of the exhaled CO2 comes from alveolar gas, and all metabolic CO2, all CO2 that is produced by our tissues, is cleared through the lungs unless you're on ECMO, because ECMO is extracorporeal CO2 elimination. So this is perhaps the most important mathematical relationship related to pulmonary ventilation. And that is that your arterial PCO2 and your patient's arterial PCO2 is determined by the amount of carbon dioxide that is produced divided by the alveolar ventilation times a factor. And what this factor 0.863 does is it converts between different units and different measurement standards and so forth. So for example, a normal carbon dioxide production is about 200 milliliters per minute. And that's usually reported in standard conditions, standard temperature and pressure drop. Normal alveolar ventilation is about 4¼ liters per minute, body temperature and pressure conditions. So if you plug those numbers into this equation, hi Lloyd,
Morning.
if you take 200 divided by 4.25 and multiply it times 0.863, it should give you a PCO2 of 40. You can double check me on the math. You can take out your phone and do it. It actually comes out to be, I think, 40.6 or something like that.
He's a Harvard professor.
Bob's the Harvard professor. So what this relationship then tells us is that if the alveolar ventilation goes down, if you breathe less, your PCO2 goes up, as we know. It also tells us that if the amount of carbon dioxide that is produced goes up, then the PCO2 will go up unless you proportionally increase your alveolar ventilation, which is the normal response. So all of us, if we exercise, when we exercise, we increase our CO2 production, metabolic CO2 production, and our alveolar ventilation goes up, we breathe more, and our PCO2 does not change, or if anything, goes down a tiny bit. So what things then can affect carbon dioxide production? Well, again, normal is about 200 milliliters per minute. So if you take the NICO, or the NM3, I guess is what it's called now, and you hook it up to a patient, you measure the CO2 production. We'll talk more about that in a minute, how that's done. Normal is about 200 milliliters per minute. So that's about 2.8 milliliters per kilogram per minute of carbon dioxide production. CO2 production is increased with sepsis and fever and exercise and increased work or breathing. Normally our respiratory muscles don't make a lot of CO2, but if we have an increased work or breathing, they can make a lot of CO2, as can be the case in patients with COPD, for example. And excessive calories can drive up the CO2 production, especially with excessive carbohydrate calories. And years ago, that used to be an issue. Back in the 1980s and into the 1990s, where patients would get a lot of calories. And then sometimes we couldn't get them off of the ventilator because their minute ventilation was too high, and their caloric intake would be adjusted, and then they could come off of the ventilator. Not so much, I don't think, an issue anymore, because this is pretty well appreciated. Carbon dioxide production is decreased with sedation and paralysis and decreased body mass. So back in the day when I was putting the NICO on patients and measuring CO2 production, it would not be unusual that the CO2 production would be 130, 140, 150 milliliters per minute, less than normal, because many times those patients were sedated and paralyzed. So that decreases the amount of tissue CO2 production. Decreased body mass can also decrease CO2 production. So if you have fewer cells that are making CO2, there will be less CO2 production. I remember from about 15 years ago, there was a patient whose CO2 production was less than 100 milliliters per minute. And we were scratching our heads for a couple of days and trying different sensors on the NICO and so forth. And then it occurred to us that this was a little tiny patient who weighed about 70 pounds. And if you figured out the CO2 production as milliliters per kilogram per minute, that was actually normal for that patient. oh, back to here. So increased CO2 production results in a higher minute ventilation or a higher PCO2, as we had said on the previous slide, and paralysis can reduce CO2 production, PCO2, and minute ventilation, and we see that sometimes clinically, where a patient who is very actively breathing on the ventilator and maybe is asynchronous with the ventilator and then gets paralyzed, and their PCO2 goes down. And this is the mechanism of that. Okay, a little bit more math. You know, I like math, so lots of equations. So the CO2 production is equal to the minute ventilation times the amount of CO2 in the exhaled gas, the mixed exhaled PCO2, the average CO2 in the exhaled gas, and in a minute we'll talk about how we get that, divided by the barometric pressure. As we had already said, CO2 production is an end product of metabolism or energy expenditure by the cells. So we can then use this equation to calculate the resting energy expenditure, as you know. So you can take the CO2 production in liters per minute times a factor 5.52 kilocalories per liter of CO2 multiplied by the number of minutes in a day, 1,440, and in that way we can calculate a patient's resting energy expenditure, as probably still do sometimes. Certainly we're doing it a couple of years ago when I was around here most days. And this actually comes from, not to pat myself on the back, but this actually comes from a paper that I published more than 30 years ago. And I know I used to get questions from people in some of the units about where this equation came from, and I would pull out this ancient paper and show it to them. I had to chuckle.
Show them how you made it up?
That's I made it up. Actually, I didn't make it up.
Pencil and paper, the math.
So, so I used to do the calculation with a slide rule.
Oh, yeah, right.
But I had to chuckle when about a year or so ago there were a couple of papers that came out of children's across town where they described the measurement of energy expenditure based upon CO2 alone rather than a metabolic part, and published in their papers an equation very similar to this. But somehow along the line they missed this very important paper that was published many years ago. So they published their work as though they come up with something new. So I guess the point is there's never anything that's new.
That's true.
So how do we get mixed exhaled carbon dioxide? So here's the way that we used to do it years ago. And here's the way that I used to do it in the MICU, and I think we used to do it this way over in the old RICU. Years ago, we would take a gas collection bag, hook it up in the expiratory port of the ventilator, and we used one-time Douglas bags, and then we used these big leather balloons, so we had these big balloons full of gas. Remember that, Linda? And then we would take a sample of that gas and send it to the blood gas lab, and then they would all always call back and say there's no blood in that. And they would give us the PCO2, and that's how we got mixed exhale PCO2, and then you could do the math. Well, the problem with that today is it doesn't work. And the reason it doesn't work is because most ventilators now have a bias flow that goes through the circuit during exhalation. That bias flow is CO2 free. So what it would end up doing is adding a lot of gas to the bag that has no CO2 and does not come from the patient. So there, I know even up to a couple of years ago, we would get requests, I would get requests sometimes about doing, showing the fellows how to do the old Douglas bag collection. Well, there's nothing to show because it would be flawed to try to do that.
So you could probably do it if you were willing to measure the volume into the bag and you had a large enough bag where you could accommodate the bias flow.
If you knew what the bias, you are
but you still
correct. It would be some mathematical gymnastics. But if you knew what the bias flow was,
Yep.
and if you knew that that gas was CO2 free, you could correct for it. But it would fill up the bag a whole lot faster.
You need a bigger bag.
So maybe somebody knows. I saw Vinny just walk by. He would know.
1.5 liters per minute.
I think if you have the flow trigger on the Puritan Bennett set at 2, the bias flow is 1.5 liters per minute more than that.
Right,
Or
so if
something
you
like
could set it
that.
on pressure trigger, and it would
Yeah, that might give, I don't know what the bias flow is on
Well,
that.
There still is a bias.
Yeah, there
It's
still is
the-
some.
Yeah.
So then, how do we get around that? Well, we get around that by using this device that you have all seen, so that we measure the CO2 directly at the patient, so that this gas is not contaminated by any bias flow through the circuit. So we use the NM3 or we use the NICO, and that gets around the problem because the adapter fits right on the patient's airway. And this is how it does that. So this is a capnogram, as we'll talk about in a minute. So this is exhaled CO2 as a function of exhaled volume. So in the NICO adapter, it measures not only carbon dioxide concentration, but it also measures flow and volume. So it produces a volumetric, a volume-based capnogram, and the area under the curve is the CO2 production. So if you take percent CO2 times volume, that gives you the CO2 production. So the software in the NICO does this integration and gives CO2 production. So here's our relationship again. CO2 production, or PCO2 is equal to CO2 production divided by alveolar ventilation times a correction factor. We talked about CO2 production. Now how do we get alveolar ventilation? So let's talk about the denominator for a few minutes. So minute ventilation is equal to dead space ventilation plus alveolar ventilation. So if the dead space increases, either the alveolar ventilation will need to increase or the PCO2 will need to increase if the minute ventilation is constant. Or if the dead space increases, the minute ventilation must increase for alveolar ventilation and PCO2 to remain constant. So then if a patient develops a pulmonary embolus, which increases the dead space, they will try to protect their PCO2, so they will increase their minute ventilation, and the probably the most common clinical sign, or a common sensitive but not specific clinical sign of pulmonary embolus is tachypnea. So patients with PE are typically tachypneic for this reason. So let's illustrate what some of this means. So normally our dead space is about 1/3 of our tidal volume. So normal dead space is about 150 milliliters. Normal tidal volume is about 400 milliliters. So a normal dead space to tidal volume ratio is about 1/3. So normally, with a normal dead space of 1/3 and a normal PCO2, we need a minute ventilation of about 6 liters per minute or so. However, what happens if we get a PE and our dead space increases to 75%? Now, for a dead space of 75%, to keep the same PCO2, we'd have to increase our minute ventilation to more than 15 liters per minute. And that may not be sustainable for a long time. So what happens is often we end up somewhere in the middle. So we have a dead space of 75%. We might only increase our minute ventilation to 10 liters per minute, but that means we end up with a PCO2 of about 70. So physiologic dead space is ventilation without perfusion. The physiologic dead space is the sum of the mechanical dead space, the anatomic dead space, and any alveolar dead space that we might have. The mechanical dead space is the amount of tubing that goes between the artificial airway and the Y-piece on the ventilator circuit. And that has the effect of increasing the amount of anatomic dead space. So if we put a 50 milliliter piece of dead space on the ventilator circuit, then that means that the patient's minute ventilation needs to go up, or their PCO2 will go up, particularly if we are using a tidal volume of 6 mLs per kilo. So 20 years ago, when everybody got a tidal volume of 1 liter, putting that piece of flux tubing on there didn't make much difference. But now when everybody gets a tidal volume of 350 or 400 milliliters, that can make a big difference, which is why I don't think we use those flex tubes anymore. A couple of years ago when I was around, we never used those flex tubes anymore. And I can remember the time, 15 years ago probably, when we went through the MICU and took all of those flex tubes off of the ventilator circuit.
More swivels?
Yeah, the old Mork swivels.
Yeah.
As we were adopting lower tidal volumes, then everybody was ending up being more hypercarbic. And interestingly, anecdotally, we took out the dead space and patients' PCO2s went down, which I thought, well, that makes sense. And then there have been a half dozen papers that have been published since that about how if you remove the mechanical dead space, patients will have lower PCO2s. And I'll show you one of those studies in just a minute. The anatomic dead space is just a part of the lung that does not have alveoli, so that's primarily the conducting airways. Normally we have very little alveolar dead space, but if there is anything that compromises blood flow through the lung, so we have ventilation without blood flow, that contributes to dead space, such as the classic example is with pulmonary embolism. So the result of an increased dead space is there's an increase in minute ventilation or an increase in PCO2. So here's one of those studies, published more than 10 years ago now in Respiratory Care, showing the effect of mechanical dead space or apparatus dead space on PCO2. So the open bar is the PCO2. So this is with minimal dead space, essentially the Y connector going right on to the endotracheal tube. This is with just the 50 milliliter traditional dead space that we had used in years past. And then this is with the addition of an HME as well as the tubing. And look at what happens to the PCO2 for the same minute ventilation. And that's, you would say, well, how much of an effect is that? Well, it's more, on average, more than 10 millimeters of mercury increase in PCO2 by adding the swivel tubing, the Mork swivel, and an HME. So also a reason why I'm not real keen about using HMEs for long-term ventilation is that if we are using low tidal volume ventilation, lung protective ventilation, adding the dead space of that device can result in the PCO2 going up. Now, it also varies from device to device. Some HMEs have a dead space of approaching 100 milliliters. So that's a lot when the tidal volume is set on 350. The ones that we use are about 15 ml.
We just looked it up yesterday, right? Or
It's more than that.
28. Right.
28. Okay, so
28, that's all?
better than 50.
It's a lot though
But-
if you use a 6-inch corrugated tubing,
In
like
addition
you were
to-
saying.
Yeah. So you could go through the math. This could be your next assignment, is to go through the math and how much does that 28 milliliters affect the dead space over a minute with a tidal volume of 300 milliliters per cup, or 350 or whatever.
There goes the afternoon.
So before I leave today. So dead space is often expressed as the relationship between dead space and tidal volume, or total dead space ventilation to total ventilation. Causes of an increased alveolar dead space, the classic one that we have already mentioned a few times is pulmonary embolism. Other things that can increase dead space is alveolar hyperinflation, such as with COPD or acute asthma. So patients with COPD, if you measure their dead space, it's not unusual for patients with more severe COPD, that can be 70 or 80% dead space fraction because of the hyperinflation. Also because of destruction of pulmonary circulation. With stable asthma, the dead space tends to be normal, but with an acute asthma, with hyperinflation, the dead space goes up. it's not unusual. For example, patients with severe acute asthma who get intubated at a PCO2 over 100, for example, because of the high dead space. And the effect of PEEP, and I'll illustrate this in a minute, is that PEEP, if it results in hyperinflation, can result in an increase in dead space. I'll show you some data to support that in a minute. And with pulmonary hypoperfusion, such as cardiac arrest, there will be an increase in dead space. And in fact, with no pulmonary blood flow, it's 100% dead space. It's all ventilation without blood flow, making the case for monitoring end-tidal PCO2 during resuscitation, and I'll come back and talk about that a bit more in a few minutes. Normal dead space is about a third, 0.2 to 0.4. Clinical implication of dead space is that it will result in either a higher minute ventilation requirement or a higher PCO2, or both. So what about the effect of PEEP on dead space? So this is a classic paper from back in 1975. I could ask how many in the room were alive then? 3 of us? 4 of us?
3.
5 of us?
1, 2,
Oh,
3,
maybe
4,
half of them.
5.
That many?
We don't hold your youth and experience.
Okay, who is alive then? You, oh, okay.
6. 4.
There you go. All right. At any rate, who remembers when this paper came out? Now we're down to 5. I could say, who is alive and a respiratory therapist? So in this classic paper, published in the New England Journal of Medicine back in 1975.
And the study was done here.
Yes,
Peter was
correct.
here.
Peter Suter was here at the time, and
as
then
a
he
fellow.
went on to San Francisco, I believe.
Went
back
to San
to
Francisco
Europe.
and then he went back to Switzerland.
Yeah. So this was an old RICU study
Right?
Wow.
before Linda.
When the RICU was in the Phillips house.
There you go. So it was probably Cubicle J, isn't that where they did all the studies when it was?
In the Jackson, yeah.
Right. But
So, at any rate.
This was before that, I believe.
Yeah, when it was,
Yeah. So Cubicle J, I think, is where they did all the ECMO stuff. So at any rate, enough reminiscing for now. So they identified best PEEP, and I won't get into the details of how they did that. And then they looked at a variety of physiologic parameters when they either decreased the amount of PEEP, so they lowered the PEEP, or they increased the PEEP. And what did they show? Well, one of the things they measured was VDVT, and noticed that the lowest dead space corresponded to the best PEEP. And when the PEEP was decreased, the dead space went up. The implication of that would be that the PCO2 goes up. And when the dead space was increased, that also resulted in the dead space going up. So this is a loss of recruitment, this is an overdistension, and the effect on dead space. So then you might say, well, this came out in 1975, so then why don't we measure dead space to determine best PEEP?
It's easier to measure compliance.
Because it's easier to measure compliance. So if you look at compliance, the highest compliance corresponded to the lowest dead space in the best PEEP. So it's a heck of a lot easier to measure compliance than it is to measure dead space. Even with the NICO, I would argue it's much easier to measure dead space than when we had our old gas collection bags. But that said, it's a lot easier, I think we would all agree, to measure compliance, to calculate compliance than dead space. So this is an interesting slide when we're talking about dead space. From a clinical standpoint, it does not make the case that we should be measuring dead space for best PEEP. Okay, so let's talk a little bit about the capnogram, capnography. Something which is quite popular some places around the country where every ventilated patient is hooked up to a capnograph. And as I'm learning, that's probably more common than I appreciated. I teach a course, a couple courses at Northeastern, in the Master's Respiratory program, where their students, it's an online course, are students from all over, actually all over the world. And some of them are shocked about some of the things I say about capnography because it's so ingrained into them that this is something we have to have. So illustrated here is a normal capnogram, measuring CO2 coming out of the airway. So the first gas that comes out of the airway is dead space gas, and dead space gas is CO2 free, unless you're rebreathing gas. So this is dead space, phase 1, dead space, no CO2. And then as alveolar gas begins to exit the airway, there is an increase in exhaled CO2, and this is called phase 2. Now, a question that I ask you, I used to always ask the fellows when we talked about this, why isn't this square? So if this is dead space and then this is alveolar gas, why doesn't this just go straight up, continue over here, and look like a rectangle? And the answer is because there is heterogeneity within the lungs, and not every alveolus in the lungs has the same PCO2. And we'll come back to that point in a few minutes. So there is a lot of heterogeneity even in the lungs of normal people, much, much, much more heterogeneity in the lungs of sick patients. So this does not abruptly increase because we don't have one airway and one alveolus. If we just had one alveolus and one airway, they would go straight up, stay at that, straight down. So this reflects the heterogeneity of ventilation in the lungs. And then phase 3 is often called the alveolar plateau. It's not quite a plateau. There is some slope to phase 3, but that reflects gas that is coming from the alveolar space. And then at the end of exhalation is the end tidal PCO2, which is 99.9% of the time is the maximum exhaled PCO2. So this then, the end tidal PCO2 reflects the alveolar PCO2 at the end of exhalation. So it's very important to appreciate, as I think we all do, that the end tidal PCO2 is not the arterial PCO2. So imagine this case where we have two alveoli. And in this lung unit, there is an obstruction, say a clot, like a pulmonary embolus. So there's no blood flow past this alveolus, but it's being ventilated. So in this alveolus, the PCO2 is the same as the inspired PCO2, because there's no CO2 that comes out of the blood into this alveolus. Whereas in this alveolus, it's being ventilated and perfused. And in this lung unit, the alveolar PCO2 at end exhalation will be very similar to the arterial PCO2. But if you measure the PCO2 coming out of the lungs at the end of exhalation, it'll be half this and half this. So there will be a big difference between what comes out of the lungs and what is in the arterial blood. In this case, if the arterial PCO2 is 40, the end tidal PCO2 would be 20, half of that. And now you can imagine if you add to this 300 million alveoli that have all kinds of different ventilation-perfusion relationships. So a lot of caution is necessary when trying to make out the meaning of the end tidal PCO2 related to the arterial PCO2. So normally, you and me, with pretty normal ventilation-perfusion relationship in the lungs, the end tidal PCO2 will approximate the arterial PCO2 within a few millimeters of mercury. So then one might argue, well, if the lung function of the patient is relatively normal, then the end tidal PCO2 might be a reasonable proxy for the arterial PCO2. And from the physiology, I would accept that. The point is, though, that usually we put patients on ventilators who don't have normal lungs. So what happens if the lung function is abnormal? So let's imagine that there's an increase in dead space. So now there is a lot of ventilation relative to blood flow. In this case, the end tidal PCO2 may more closely reflect the inspired PCO2. So there will be a big gradient between the arterial and the end tidal PCO2. as I showed on the previous slide. The end tidal PCO2 may be 50, the end tidal PCO2 may be 30, and the arterial PCO2 may be 50. Now let's look at the other extreme, decreased ventilation perfusion relationship in the lungs. In this case, the end tidal PCO2 may more closely reflect the mixed venous PCO2, which is a couple of millimeters of mercury greater than the arterial PCO2. So then, depending upon the patient's lung function, the end tidal PCO2 may be a little bit greater than the arterial PCO2, or it could be 0 with cardiac arrest. And in our individual patient, we often do not know which of these physiologies predominate in that patient. So we need to be very cautious about using the end tidal PCO2 as a proxy for arterial PCO2 in patients with abnormal lung function. I can recall for some of our teaching sessions in the MICU, we would put on the NICO and we'd go through some of this physiology, and remember some of the looks on residents' faces when a patient would have an arterial PCO2 of 80, and we put on the NICO and the end tidal PCO2 would be 25. And I always make the point that if we were monitoring only the end tidal PCO2 and managing the ventilator based upon that, we would be making a big mistake in care of that patient.
So that's why we don't do it.
Right.
You know, other than in patients with healthy lungs, it's very misleading data.
Correct.
And it can lead to more air than it can lead in benefit to the way you ventilate patients.
Yeah, and in the scenario that I just gave, you could do real harm to the patient.
I'm going to tell the PICU that.
Pardon?
I'm going to tell the PICU that. Stop using it. I'm just kidding.
Many have told the
They're welcome to come and sit in on the talk. Now, there's other information that you can get off of the capnogram, if you're so interested. So one thing you can do is you can use an old method called the Fowler's method that goes back, I think, to the 1930s, even before I was born. And this is used to determine the anatomic dead space. So we take the capnogram and we add this vertical line so that the area of this rectangle P is equal to the area of this rectangle Q. Then from here to here is the anatomic dead space. So the NICO, if you look at all of those numbers that it puts on the screen, one of the numbers that it gives is anatomic dead space. So if you're interested in that, you can get it off of that machine, and this is how it does it. So in the software, it does this to get the anatomic dead space. And then there is a lot on this slide, but let me point out a few things about it. So one of the things we already talked about is you can do this area P, this area Q, you can determine the airway dead space, the anatomic dead space. The other thing that can be done is to determine the point midway along the phase 3, and that is considered the average alveolar PCO2. So if you take that average alveolar PCO2, you can plug it into the Bohr equation to determine alveolar PCO2, or alveolar dead space, I should say. So you can take this average alveolar PCO2, plug it into the Bohr equation, determine the physiologic dead space. Now, the way that more commonly dead space has been measured is by using the Angoff technique. And with the Angoff technique, we use the mixed exhale PCO2 rather than this alveolar PCO2. So why did that happen? So why did we go from using, I'm sorry, I think I said that wrong. We used the arterial PCO2 rather than the alveolar PCO2. So I said that wrong, I think. Before.
No, you said it right.
Did I say it right?
Yeah.
Okay. So then why did, over the years, we go from calculating dead space based upon the arterial PCO2 rather than this average alveolar PCO2? And the reason was that for many, many years, it was difficult to determine this point. So you would have to essentially print out the capnogram. You would have to visually inspect it, find this point, and then do the calculation. Whereas it was much easier to get a blood gas and to get a mixed exhale CO2 in the bag and use the Angoff method. The problem is that the Angoff method includes not only dead space but shunt. So if we measure the dead space as we have commonly done it, by using the mixed exhale PCO2 and the arterial PCO2, that includes shunt as well as dead space. So it'll overestimate the dead space. And then this is a point that I made earlier, is that the PCO2s are different in different alveoli. So in you and me, the difference in PCO2s among alveoli due to heterogeneity is not very large, maybe a few millimeters of mercury. However, in patients with lung disease, there can be great differences, 10, 20, 30 millimeters of mercury difference in PCO2 from one alveolus to another due to different ventilation perfusion. So then when we look at our capnogram, what we are looking at is an average of all of those PCO2s, including low VQ regions and high VQ regions. So it's an average. It does not account for the heterogeneity. The other thing is that the PCO2, as is illustrated by this line, goes up and down over the breathing cycle. So the CO2 goes up during exhalation, down during inhalation, up during exhalation. So that then is a reason to try to use this point as the average alveolar PCO2, because it takes the PCO2 over the respiratory cycle. This is a study that we published in Respiratory Care just a few years ago, back in 2010, which I like to make the point of being careful about using end-tidal PCO2 in patients with lung disease. And what they showed very nicely in this study is that in patients who had a normal dead space, the difference between the arterial and the end-tidal PCO2 was relatively small, within a few millimeters of mercury of being no difference. But notice, as the dead space increases, the difference between the arterial and the end-tidal PCO2 increases. So in a patient who has a dead space of over 70%, like a patient with severe acute asthma or a patient with ARDS, notice that now, on average, there's almost a 20 millimeter of mercury difference between arterial and end-tidal PCO2, also with a lot of scatter. And then this is just another way of saying what I had already said, is that the end-tidal PCO2 is a mix of gas coming from normal lung units, low VQ, high VQ, and we can pick certain points off the capnogram to try to adjust a little bit for that, like using the Bohr equation rather than the Angoff equation and so forth. Something that I'm not sure of is whether the NICO will do both. It seems like it should, but I always put in the arterial PCO2, which meant that it was the Angoff approach. I don't know if it does the other one. It seems like it should. Okay, a little bit about capnography and CPR. So are you doing capnography during codes now?
We're supposed to.
I spent my last 10 years here, as some of you know, working on that, and it still hadn't happened by the time I left. But then I did get an email from the chair of the code committee some time ago that said, "Hooray!" So I assume that meant that it's happening.
You're in
now.
with the defibrillator.
Yeah.
Yeah, so we're using them more often now.
Good, because I think that is a place where the use of capnography makes sense. And here's the reason why. The end-tidal PCO2 will be 0 with 100% dead space, no pulmonary blood flow. So with a cardiac arrest, no blood flow through the lungs, 100% dead space. So that means that the end-tidal PCO2 would be 0. The end-tidal PCO2 then can be used to assess CPR effectiveness. There is a poor prognosis if the end-tidal PCO2 is less than 10 millimeters of mercury after 20 minutes of CPR. So essentially what this means is if the end-tidal PCO2 is approaching 0 after 20 minutes of CPR, there's very little blood flow. And if there's very little pulmonary blood flow, there's very little cerebral blood flow. And if there's very little cerebral blood flow, the brain is hypoxic, anoxic.
So we should not put these kind of patients on ECMO.
Oh, is that
Contrary-
was that
contrary to
was that
popular
supposed to be
opinion
one of
around
the
here.
objectives today? An abrupt increase. Now, I think it might what Bob said. He may not agree with me, but if the end-tidal PCO2 is 25 after 20 minutes of CPR, that's a different story. An abrupt increase in end-tidal PCO2 indicates a return of spontaneous circulation. So here are a couple of examples. So here is the end-tidal PCO2 in a patient who is being coded. The end-tidal PCO2 is very low, only about 10 millimeters of mercury. And then notice here it drops even more, goes down to close to 0. So what this suggests is that the person who's doing the compressions is getting tired. So the compressions are less effective, pulmonary blood flow is less effective, the resuscitator is changed, and clearly whoever this is doing a better job than this person. And then here is an example of a patient who has a return of spontaneous circulation. So here you can see that the end-tidal PCO2 shoots up to actually over 40 millimeters of mercury with the return of spontaneous circulation. So the patient got shocked here. So CPR was stopped, compressions were stopped, end-tidal PCO2 dropped to 0, patient got shocked, return of spontaneous circulation, increase in end-tidal CO2. So as I was the point that I was trying to make for years before I decided to retire is that here we think about end-tidal CO2 as a monitor of pulmonary blood flow. And there were a lot of people who couldn't get out of their heads that this was a way of looking at the arterial PCO2. Not about arterial PCO2 at all. This is a blood flow monitor in this setting, not a PCO2 monitor. The slope of the capnogram tells us about the distribution of ventilation. So, for example, imagine we have two alveoli. This alveolus has a normal airway leading to it. This alveolus has a partial obstruction. So during exhalation, this alveolus will empty slower. As this alveolus is emptying slower, the blood keeps dumping CO2 into the alveolus, so this alveolus will have a higher PCO2. And as a result of that, the slope of the capnogram goes up. So in patients with COPD or severe asthma, the capnogram will look like this, an increase in the slope. Phase 3, that tells us that there's heterogeneity within the lungs. And in fact, in the patient with severe acute asthma, if we treat them with bronchodilators, it goes like this again. And there are papers in the emergency medicine literature dating back 20 years that show that in a patient with severe acute asthma who comes into the emergency department, you put a capnogram on, you see this, you give them bronchodilator, it goes like this, so you can use it to assess the response to the bronchodilator. So why doesn't Lloyd run down to the ED with a capnograph every time a patient with asthma comes in?
And just treat them symptomatically. When they start looking better,
Well,
I'm pretty sure it's good.
As I've told folks when they've asked me that question, an echo costs $15,000. A peak flow meter costs $25. So, you get the same information, right? So. And then this is from a patient, I've used this slide a lot over the years, so some of you may have seen it before. This is a patient with a unilateral lung transplant who was up in the MICU about 15 years ago probably. And she has severe emphysema. Her left lung was transplanted, so this is the transplanted lung, this is the native lung. You can see in the native lung the degree of hyperinflation due to the emphysized COPD in that lung. In the transplanted lung, you can see all of this infiltrate. She was either rejecting or she was infected. And I don't exactly remember why we put on a capnograph, what our reason was for putting it on, but when we did, it was very interesting because this is what the capnograph looked like. And I had never seen anything so weird in all of my career up until that point, or since that point. And I'm pretty sure that what this is showing is this is the gas which is coming from the stiff lung, which is emptying first, and then this is the gas which is coming from the hyperinflated lung. So this has the increase in slope, as you would expect to see with COPD. This is a more normal appearing capnogram, as you would expect to see with restrictive lung. So I believe, to this day, I believe that what this is showing is the heterogeneity between those two lungs.
So why did Dean choose that the first part was the transplanted lung and the second part was a hyperinflated lung? Why isn't it the other way?
And by the way, you can kind of ignore, these are cardiac oscillations,
right.
so you can just kind of assume that that's gone up in a straight line.
So why wouldn't we make the interpretation the other way?
Because of the stiff lung, the air leaves that lung first, right? And so it
That's
moves
true.
out first.
That's true. But what about the level of CO2? Look at how the level drops.
Due to dead space.
Due to dead space be caused by what most likely? Significant amount of auto peak.
And hyperinflation.
And, well, the hyperinflation causing the auto peak.
And I remember the fellow said, oh, maybe we should put in a dual lumen tube. And I said, that's not what this is showing at all. I mean, a dual lumen tube you could sort out. You could answer that question, but that's sort of the wrong, long run for short slide. This patient had LAM. LAM, you know about LAM? So it's a type of COPD that occurs in women at an early age. She was in her late 30s, as I recall. Unfortunately, eventually passed away. Not on this admission, but at a later time. So LAM is it's a very rare form of severe COPD, different than alpha-1 antitrypsin that occurs in younger people and predominantly in women. And I say LAM, I was hoping that nobody would ask me what that stands for, because the word's about this long. So that's why we have Google, right?
Is
So
it
I
an
don't have to
autoimmune
right.
thing?
So, you know, I don't recall. I think it may have an hereditary basis, but I don't recall the details of that. Fortunately, it is very rare, even a lot more rare than alpha-1 antitrypsin. So this is something that was published 15 years ago now. A couple of the co-authors on this study were actually respiratory therapists. One of them is a friend of Bob and mine, Rich Calais, at San Francisco General Hospital, and they published this paper in the New England Journal showing the relationship between mortality and dead space in patients with ARDS. And what is striking here is that there is an increase in mortality with an increase in dead space. And notice that when the dead space is over 70%, that the mortality is 70% or more. So this then would suggest that patients with ARDS who have a high dead space, and we usually know that not by measuring dead space, but because they have a very high PCO2, that they have a higher likelihood of mortality. So to me, then, that would suggest that we should be doing things as we can to try to reduce the dead space. This study, when it came out, was very controversial. The mechanisms for this are probably many and not very clear. But what I can tell you is in the last 15 years, the study has been replicated at least 3 times. And they always find the same result. An increase in dead space with ARDS, the mortality is increasing. All right, this I think is my last slide, my summary slide. So with ventilation, we can think about the patient as a high minute ventilation, which could be due to a high dead space or a high CO2 production, or the hyperventilation could, or the high minute ventilation could be due to hyperventilation with a low PCO2. Or if our patient has a high dead space, that could be, if a patient has a high arterial PCO2, that could be due to a high dead space, a high CO2 production, or hypoventilation, a low minute ventilation. And then this is the mathematical relationship that explains all this. So the arterial PCO2 is roughly equal to the CO2 production divided by alveolar ventilation. And alveolar ventilation is the difference between minute ventilation and dead space ventilation. So I think that is the last one. Any comments or questions that you have? Happy to. Yes, Carolyn.
The argument that we often get in the PICU when you bring up the point of the patient has severe lung disease and PCO2.
They're probably too many.
Agreed.
Dean, how much change in blood flow do you get when you prone a patient who already has significant lung disease?
Already has what?
Significant lung disease. So our ARDS
Yeah.
patient who we're going to prone.
Yeah.
How much of the effect do you think is attributed to change in perfusion versus recruitment?
So it's so some of it's change in DQ and some of it is recruitment. I'm trying to remember if there's. I think it's still in review. I reviewed a paper for another journal recently on oxygenation effects of Crohn's, and it's actually done by Rob Glennie and really smart people. And they make the point that there are multiple reasons for the improvement in oxygenation, and it's probably all of them together. Now, in an individual patient, one may be more predominant than another. But they actually made a big case about the VQ matching, and that's actually where I got the idea to draw this slide the way that I did. But it's not. I certainly don't want to communicate that it's only VQ. So some of it is recruitment as well.
So you also know when we first started talking about prone positioning, people thought when we prone patients, we changed the distribution of perfusion so much so that we altered it from the normal relationship. But as Dean showed, there is a change in the slope, but you still have that same gradient that exists.
Yeah, it's probably more how the VQ changes than the ventilation or the perfusion by itself.
Right. There's a perception that when you flip these patients, all blood flow now goes to the anterior segments, and you have less damage than right. So that's why I wanted to bring it up.
Yeah, and in fact, it's been shown on CT studies from many years ago that when you prone patients with ARDS, what was the dorsal consolidation becomes the ventral consolidation. So which would argue for things like VQ and other things.
Well, for that, and just the change in the superimposed pressure of the heart, the great vessels, and the fluid being now shifted from the dorsal to the
so there's
ventral
less
back and
compression
forth.
of the ventral lung in a prone position.
Right, so that just opens things up when you put them. So you have a greater percentage of the lung, anterior, and as a result, that's not going to consolidate as often, so you have a greater surface area for gas exchange, and it usually improves. I mean, it's rare to see a patient prone without some improvement in oxygenation.
Okay.
Thank you,
Next
Dean.
time, I think we talk about blood flow.
According to, again, assuming vascular volume is okay, that should be the case, or that the patient has no significant cardiac problems. Now, if somebody's got significant cardiac problems, maybe not, but if they're reasonably stable cardiac-wise and got good vascular volume, they should be okay.
Yeah, I mean, I illustrated the effect of hypovolemia, which is also to reduce the diameter of the pulmonary capillary and increase PPR.
Right.
Yes, Steve.
What's
What's the cost of Belitri for the day versus nitrate for the day?
About a 20-to-1 difference.
20 to 1?
Yep.
Okay.
Belitri, Dan, help me here. Belitri, I think, costs $100.
Huh?
$200 a day for Belitri.
Right.
200, okay.
It's $150 an hour for nitric.
Right, I used to
50
say,
per hour?
when I would be asked this question,
So figure it out, it's about a 20-to-1.
Wow.
yeah, when I was asked this,
It was
when
pricey.
I get asked this question, my typical response is that 1 hour of nitric costs about the same as 1 day.